those murmurs in the first few days of life, really think hard about those and make sure that you don't see any signs of reduced pulses. You don't see any evidence of cyanosis. You don't see any evidence of heart failure symptoms.
During a routine physical for a healthy appearing child, you place your stethoscope on the chest, and there it is. A sound that you need to spend a little more time listening to. A murmur wasn't on the agenda for that visit. You ask yourself, have you heard it before? You check your previous documentation from earlier visits. How concerned should you be, and how do you present this information to the family? Heart murmurs are one of the most common physical findings in pediatrics, but they can instantly shift the energy in an exam room. For families, it can sound alarming, and for pediatricians, it can spark a rapid mental checklist of possibilities, patterns, and next steps. Most murmurs are harmless background music of a growing heart. Some are not. The challenge is recognizing the difference in the moment. This is Charting Pediatrics. To explore this topic, we're joined by Dr. Christopher Rausch. Chris is a pediatric cardiologist and the director of our cardiopulmonary exercise laboratory here at Children's Hospital Colorado. He is also a professor of pediatrics at the University of Colorado School of Medicine. Chris, welcome back to the podcast.
Thanks for having me.
Yeah, it's great to see you. Tell us, first of all, what causes a heart murmur? What is it exactly?
So that's a thing that causes a lot of confusion for families, especially. They think of murmur as an entity in itself that's a problem with the heart. And really, a murmur is just a sound that we hear. It's a generic term for a sound that we can hear in the heart that's caused by vibration, typically because of a change in pressure somewhere within the heart.
Thank you. And heart murmurs are something that we all learn about, we encounter regularly, but they still cause a lot of uncertainty and confusion. Why is that?
They do. A lot of families are very concerned when they hear it, and will come to the cardiology clinic in tears. And a lot of providers are.
That's a tough way to start the visit.
It's a tough way to start the visit. It's good when they turn out to be normal, and you can tell them that everything is normal. They're very happy with that result. But they come in with a lot of anxiety when at a well child visit, a child or baby that they thought was totally healthy, now they're told has this heart murmur. And for clinicians, it can be a challenge just to differentiate, a normal sounding murmur, which is very common, versus one that's not normal, something that's dangerous or in rare cases, life-threatening.
Now, we do know that most of these murmurs are going to be innocent or benign, right?
That's right. So in the general population, about 1 in 100 babies is born with congenital heart disease. Now, up to 75% of kids will have a heart murmur at some point in childhood and development.
Wow, I had no idea it was that high. That's amazing.
So really high, and because of that, we know that most of those are normal, with only 1% of them being congenital heart disease.
So, thinking about the physical exam and how you as a cardiologist use your stethoscope, I was wondering if you could walk us through your exam and then point out some of the characteristics that might help distinguish an innocent murmur from a pathologic one.
Definitely. So as I'm putting the stethoscope on the chest and listening to the murmur, I'm trying to picture the murmur in my head. I'm listening to the first and second heart sounds, S1 being the closure of those atrioventricular valves, the AV valves between the top and bottom chambers of the heart, and at the same time, the opening of the semilunar valves, the aortic and pulmonary valves going out to the body and the lungs. So S1 is the start of the systolic phase, and S2, that's the end of systolic phase when those semilunar valves snap shut and the atrioventricular valves open up. So as I'm listening, I'm trying to determine first of all, where am I hearing this murmur? Am I hearing it at the right upper sternal border, which might be closer to the aortic valve, or the left upper sternal border, which might be closer to the pulmonary valve? Am I hearing it at the left lower sternal border, close to the tricuspid valve, or out near the apex where it might be closer to the mitral valve? In addition to the location on the chest, I'm listening to what is the timing? Where in the cardiac cycle is this murmur happening? Is it during that systolic phase between S1 and S2, or is it between S2 and S1? That can be a challenge for some folks trying to determine which part of the cardiac cycle they're hearing the sound. So you can put your finger on a pulse and feel the pulsation, and that will tell you during the pulse that's the systolic phase. So you'll know that's a systolic murmur. And then that can help you differentiate systolic versus diastolic.
And then, well, I like this idea of taking something that's an auditory physical finding, and you're trying to picture kind of in 3 dimensions what actually is happening in the heart.
Mm-hmm. Yes, and by doing that, you can get a sense of not only what valves might be involved or where in the heart the sound might be happening, but it also helps you differentiate between different types of murmurs. So when I'm listening, in addition to the location, in addition to the systolic versus diastolic, I'm listening to how loud this murmur is. So we're all familiar with the grading scale of 1 to 6 to grade a murmur. I typically think of 1 through 3 as being a little bit subjective, but if it's as loud as the heart sounds, the S1 and S2 heart sounds, then I would call that a 3. And if it's not quite that loud, I'd call it a 2. And if I can barely hear it, I'd call it a 1. To bump up to a 4 on that grading scale of 1 to 6, there has to be a thrill or a vibration in the chest wall present. So anytime you feel a thrill, even if the murmur it doesn't seem that loud, it's automatically a 4. And then 5 and 6 are a little bit arbitrary in terms of...
Can you hear those across the room?
You can hear exactly.
That sounds... I'm not sure I've heard a 5 or 6 in my career, but maybe I haven't been listening closely enough across the room. What are some features, I guess, of innocent murmurs
mm-hmm.
that go back to your description of the exam that would be reassuring to a clinician?
So innocent murmurs are most commonly going to be very vibratory in their quality. They're going to be systolic. So a diastolic murmur immediately makes me start to worry a little bit more about something being abnormal. Systolic murmur that's very vibratory, sort of like a twanging of a guitar string that you hear at the left lower sternal border. That starts to make me think about an innocent murmur like a Stills murmur. That's probably the most common innocent murmur we'll see. Those murmurs will generally be louder when you're laying down and get quieter when you stand up. So they may disappear entirely when you're sitting up or standing up, but they definitely will get quieter with that position change. That's very reassuring to me that this is an innocent murmur.
Now, Chris, are there specific ages or clinical settings where hearing a murmur might raise more concern for you?
Definitely. So the younger, the more likely a murmur is to be abnormal. So in a 2-day-old, I'm much more worried when I hear a murmur, even though everybody has a PDA when they're born, and all those PDAs close in the first few days of life. So everybody has, at some point in those first few days of life, has a murmur of a PDA closing. But a murmur that's persistent in that early part of life is much more worrisome than a murmur that you hear in a 14 or 15-year-old who's lived a very healthy life up to that point with no other signs of cardiac disease. Those early murmurs, then we have to think about structural congenital heart disease in really rare cases. So we said congenital heart disease is present in about 1 in 100. About 2 in 500 of those is critical congenital heart disease, the type of heart disease that has to be treated within the first weeks or months of life, or else there's a risk of death.
Right. That speaks to the timing of getting help. So from the standpoint of consultation, it sounds to me like if you're hearing a murmur in a newborn that you're concerned about, that raises the stakes in terms of getting it evaluated.
Definitely. So those murmurs early on are ones that you have to be much more intentional about being sure that this is not congenital heart disease. So things that can help you with that is the rest of your physical exam will certainly help you differentiate a PDA closing or an innocent murmur of peripheral pulmonic stenosis, which is also really common in newborns, which is caused by the blood flow through the small pulmonary arteries after birth, that you just get turbulence and makes kind of a whooshing flow that you hear out into the lungs and in the back. That's a very common innocent murmur in childhood. But trying to differentiate that closing PDA versus PPS against something that's more critical and needs to be addressed. So looking at things like oxygen saturations, especially a lower extremity oxygen saturation. If those are abnormally low, then that makes you start to worry about congenital heart disease. Feeling pulses in the arm and the leg. If you feel a difference in those pulses, you start to worry about things like coarctation of the aorta or hypoplastic left heart syndrome.
So a number of different other physical exam findings can be really important in that setting. I'm curious as to kind of other red flags that maybe that have to do with the history of the patient that we should be thinking about when we're evaluating a patient with murmur.
Mm-hmm. So whenever you're seeing the young patients with a murmur, you're especially looking for tachypnea, difficulty breathing, difficulty with feeding. So not so much that kids sort of eat well and then get tired and fall asleep. That's when parents oftentimes will get that confused when I ask them, does your child get tired when they're sleeping? I'm talking more about working really hard to breathe and having to stop and catch your breath while you're feeding, having to have very short feeding sessions that are only a couple of minutes because the child gets very sweaty and is working hard to breathe and just looks exhausted.
So you mentioned Still's murmur and PPS murmurs as two of the more common innocent types of murmurs. Are there other classic innocent murmurs that we should be familiar with?
There's the murmur of pulmonary flow. Sometimes we hear that in teenagers. That can be a little bit hard to differentiate from an atrial septal defect or mild pulmonary valve stenosis. But typically it's a bit softer, a little bit more musical or vibratory. And you usually hear that up at that pulmonic area at the left upper sternal border.
So you've talked to us a little bit about how we as primary care providers should be evaluating these patients when we see them, perhaps in the nursery after birth. Let's say there's concern for the murmur that prompts a referral to you. Walk us through your approach as a cardiologist when you're seeing these patients for a murmur evaluation.
So I will typically get an electrocardiogram just to confirm that there's not any signs of heart enlargement. I will go through a thorough cardiac history and ask about, if it's a baby, again, ask about those feeding problems, ask about any blue or cyanotic episodes, ask about sweating with feeding, ask the birth history to see if there was any difficulty with heart rates or things during delivery or pregnancy. Then we'll do the physical exam and listen for features of the murmur, like a very harsh murmur, a murmur that is diastolic, or a murmur that radiates to an area that would likely be abnormal. For example, radiation to the carotids would make you suspect that the aortic valve might be narrowed. Or again, those physical exam findings like the cyanosis or weak pulses.
So Chris, I think that, the art of the exam with the stethoscope, of course, is a classic kind of pediatric cardiology in terms of the diagnosis of different types of structural heart disease. But we know in 2026 that we have amazing imaging modalities that can give us a three-dimensional reconstruction of what's going on in the heart. So how often are patients getting echocardiograms for a murmur evaluation? Is that pretty standard? Is that standard of care in 2026?
I would say it varies a little bit with age and it varies a little bit with provider. So most likely, if a child is under 3 months old and has a heart murmur, most of the time when they're referred to cardiology, they'll wind up getting an echocardiogram, unless it's a very clearly a PPS murmur. Or, which sometimes happens, by the time they get to see us in cardiology, the murmur's gone because it was that murmur of a closing ductus. But most of the time in those first few months of life, they'll wind up getting an echocardiogram. As kids get older and the likelihood of those risky critical congenital heart diseases decreases, then over time they're less and less likely to get an echocardiogram unless there is some physical exam finding or some history finding that makes us worried. So, for example, I recently saw a 16-year-old with a new murmur, and the referral said, not a Stills murmur. And so they were fairly certain on the exam at their primary care provider's office that this was not a typical innocent Stills murmur, but it had never been heard before. The family had never been told that this child had a murmur. And when we listened, we saw that it clearly was not a Stills murmur and had a more harsh sound. It was up near the pulmonic area, and the electrocardiogram showed evidence of right ventricular hypertrophy, and all of those fit with what we found, which was a big atrial septal defect that hadn't been noticed before.
Wow, that was a great catch in the office.
Absolutely.
And so in terms of the echocardiogram, I'm curious as to your thoughts on this, because you obviously have been in practice for a couple decades and been able to see the evolution of practice and understanding the anxiety that families can have around murmurs. Do you find that the echocardiogram is reassuring, or is it more reassuring than just your confidence in your exam and your personal reassurance that the murmur is benign? Or, I mean, how does the echocardiogram play a role in terms of easing the anxiety of families?
Yeah, I think that like everything, that varies from family to family. It also probably varies a little bit with what the family's expectations are when they come in. So if they are told you're going to cardiology to get an echocardiogram, then they sometimes have a hard time hearing from me that you don't need one of those. Right. Your heart sounds normal. But that being said, some families are very happy to hear, oh, we don't have to do another test. We don't need anything else done. We're very glad that we don't need an echocardiogram. So it varies from individual to individual, but there's certainly some families who do not want to leave without that test being done. So
let's hear the best Dr. Rausch reassurance for a family around a benign murmur. This is advice for our pediatric providers in the office who are seeing these patients. They know it's an innocent murmur, but they want to provide the most reassuring language. How do you approach that?
Yeah, so I say it in multiple ways, and I try to be as clear and concise, but say it in multiple ways, that this is the sound of blood flow in a normal heart, that murmur does not mean that there's anything wrong with the heart. It just means that we can hear this sound. And I often will describe similarly the sound of water going through the pipes in the walls in your house. You can hear that. You can hear the water flowing through those pipes, but that doesn't mean there's a problem with the pipes. That's the same case with an innocent murmur. The blood flow through the heart sometimes will cause some vibration that makes some sounds that we can hear, and those are not a heart problem and will never cause any problems for that child.
I like that metaphor a lot. I live in an old house, so I can appreciate that. So I'm thinking also about the different spectrum of age. We talked a lot about the early childhood age. You recently shared the story about a teenager, but a time when we know that kids are presenting for comprehensive evaluations is with sports and sports physicals. And, murmurs, if a murmur is heard during a sports physical, that can sometimes delay entry into participation in the sports, et cetera. So how do you think about murmurs that are elicited during a sports physical?
Definitely. So when I'm listening to murmurs during a sports physical, this is typically an older kid. So we're less less likely to have those critical congenital heart lesions. They've lived long enough to prove they don't have that. In that case, then we're thinking primarily about what sort of heart problems could they have that could put them at risk for sudden death during sports. In that case, I'm listening for things like hypertrophic cardiomyopathy, for example, as being one of the most common causes of sudden cardiac death in athletes, and also a really common disease in the population. About 1 in 500 people has that disease. In that case, I'm listening for a murmur that does the opposite of what we talked about for that innocent stills murmur. Hypertrophic cardiomyopathy murmur will get louder when you stand up and quieter when you lay down, related to preload in the heart. So when you stand up, you have less blood return to the heart, and you get more obstruction of flow going past that thick heart muscle on the way out of the left ventricle, and that increases the murmur. It gets louder. So murmurs that get louder standing up always make me worry a little bit more.
For hypertrophic left heart, what are the historical elements? I mean, obviously these are kids that may or may not have participated in sports, right? They may be doing a sport for the first time. So what kind of historical features do you want to ask about in that sports physical if you hear a murmur on exam?
I always ask about family history. So family history of sudden death, family history of cardiomyopathy, hypertrophic cardiomyopathy. This hypertrophic cardiomyopathy in particular is autosomal dominant in most cases. So there's typically a history in the family of somebody who died at a young age or died for unexplained reasons, or has a diagnosis of hypertrophic cardiomyopathy that they're being followed for.
So in that instance, would an electrocardiogram be sufficient to be reassuring for that specific diagnostic concern?
Definitely reassuring. It's abnormal in about 95% of hypertrophic cardiomyopathy. But if you're concerned at all about that one, that's one of the few that I would say they should be excluded from sports until they come see a cardiologist. Most murmurs, unless you're really convinced it's abnormal or very abnormal, most murmurs are going to turn out to be not something that's dangerous, especially in a kid, an older teenage age kid.
Yeah, that's super helpful, and really one of the most important, I think, things to look for in the pre-participation sports physical for all of our pediatric providers out there. So, Chris, this has been an awesome overview of murmurs in kids. As someone who's seen so many patients in consultation for a chief complaint of a murmur heard, what are the top 3 things you would want our listeners to walk away with from our conversation?
Absolutely. So I think those murmurs in the first few days of life, really think hard about those and make sure that you don't see any signs of reduced pulses. You don't see any evidence of cyanosis. You don't see any evidence of heart failure symptoms. For the older kids, any murmur that is diastolic, any murmur that's a grade 4 or greater, any murmur that gets louder when they stand up, those murmurs should be referred to cardiology for further evaluation. So a third is anytime you're not convinced that this is an innocent murmur, that's a good patient to refer.
That's right. I like that mindset. Just be committed. If you're not comfortable with how it sounds, go ahead and refer. Chris, thanks so much for being back with us and providing such incredible practical guidance for all of our listeners.
Absolutely.